Hi, everyone. Welcome to the ICA's monthly speaker series, Navigating ICBPS Conversations with Experts. We are delighted that you are here with us today to learn from Dr. Samantha Ginsburg, a certified physical therapist who specializes in treating male patients with ICBPS. Before we start, I have a few housekeeping items. Please note that this session will be recorded. If you are on camera, your video will be included in the recording. We will have a Q&A session following the presentation. To ask a general medical question, which is not personal, please use the raise hand feature in Zoom. You will be asked to unmute yourself. If you aren't speaking, please be sure to stay muted. You can also ask a question using the chat feature. Sam will answer as many questions as she can in our hour-long webinar. And finally, please complete the post-webinar survey. A link to the survey has been posted in the chat. It is time to get started. Without further ado, please welcome Sam.
Hi, everyone. Happy Monday evening. Thank you for joining us tonight. And I know it's a little late, so thank you for coming at 6 p.m. I wanted to make sure people could come after work. I'm Sam. I am a pelvic floor physical therapist who works at Thomas Jefferson University Hospital in Philadelphia, Pennsylvania. I specialize in pelvic floor physical therapy, and I treat all genders. So today we're going to be chatting about the physical therapy approach to treating male patients with interstitial cystitis or painful bladder syndrome. I really want this presentation to be interactive, so feel free to use the chat function, unmute yourself, raise your hand, and there will be allocated time at the end for questions. So first, just a little slide about me. We're going to talk a little bit about me just to get that out of the way. So I received my Doctor of Physical Therapy degree at Temple University, which is also in Philly. I'm a Philly gal. I did pelvic floor continuing education courses through the American Physical Therapy Association and Herman and Wallace. And then I had a vigorous mentorship program through Jefferson with my mentor, Nikki Dugan. And some of my hobbies, I thought it would be fun to share. I love playing tennis. I love to read, and I like cats. I love cats. My partner and I in Philly, we take care of a colony of cats and feed them and get them TNR'd. So I thought that was a little fun fact, and I think there's one or two cat pictures posted throughout the slideshow. So we're going to start with the objectives of my presentation, and from there we'll go through the presentation. Again, like I said, if you have questions, please feel free to pause me and interject. I want this to be interactive. So we're going to first start by briefly describing IC-PBS and discussing the prevalence of this in male patients. We're going to note the differing experiences in male versus female patients, as well as review pelvic floor muscles. My bread and butter is the pelvic floor, function, and how interstitial cystitis or painful bladder syndrome may impact those functions. We're going to go through the PT approach to treatment for options for male patients with IC, and then discuss the complexity of pain. That's an up-and-coming topic, pain neuroscience education, and I wanted to do a little bit of discussing that. So we're going to start with talking about what IC is, and I'm hoping all of us have some sort of understanding. Actually, we're going to start with gender and sex, so we're going to qualify kind of what I'm talking about. So I wanted to make sure I was clear before jumping into the presentation that we're going to be talking about people with penises in this presentation. I know that the word male is in my title, but I am talking about people with penises. So we're referring to the sex, and that is different than gender. I thought this gender unicorn image on the side was super helpful. I know there are a lot of words out there that people get confused with, but gender identity, gender expression, sex assigned at birth, physical attraction, and emotional attraction are actually all very separate things. So I wanted to make sure that I qualified that before we jumped into the presentation. And if there's any questions about that, there's some really great resources online. The Trans Student Educational Resource is who created this graphic here. And then the Fenway Institute. If you Google that, they actually have a glossary of terms. And I know I have a lot of patients that ask, like, where can I get the definitions of gender, sex, gender expression? The Fenway Institute is one of those places to do that. And so again, in this presentation, it's geared towards people with penises. I will be saying male going forward, but that is a complex topic. And so not everyone with a penis identifies as male. Okay. So, and I do have a cat of my own, and if you hear her, I apologize. So we're going to go into the definition of IC. So I started by showing what the ICA had as definition. It was a really great definition. So we're starting with interstitial cystitis or painful bladder syndrome, or as we call it, IC or BPS, is a condition that consists of recurring pelvic pain, pressure, or discomfort in the bladder and pelvic region, often associated with urinary frequency and urgency. I really like that definition because it's in depth. A definition that I found in a research article done by the VA said that it is defined as an unpleasant sensation perceived to be related to the urinary bladder persisting for more than 6 weeks. I find it very apt that there are more than multiple definitions for interstitial cystitis. There's even more words. It's IC or PBS. There is no consistent definition out there, which is frustrating because people trying to find answers about their diagnosis are confused. They're like, wait, is it IBS or IBS, IC or PBS? And they're kind of confused by that. So I wanted to ask everyone how they describe their interstitial cystitis. You can say that in the chat, you can unmute yourself, but I want to know the words, the adjectives that everyone here uses to describe their symptoms, because our words matter. So feel free to unmute yourself, send in the chat what words that you use, and we'll go from there. And if you don't feel comfortable doing so, that's all right. You can fill in the time with some of my adjectives. I'm going to give us
I think if you're here, go. Okay.
I hear you.
Okay. Didn't know whether you could hear me or not.
I could, yeah.
I think just the definition on top is quite similar to my own definition. So I think that sums it up in a nutshell. Yeah.
Yeah, awesome. And so, yeah, that is a super in-depth definition. I see pain, urgency works for somebody. For Rich, Bob says interstitial cystitis is what they use. And in terms of adjectives, I'm looking for words like burning, pressure, urgency. So having my patients identify what they feel is super important because I think a lot of us get super overwhelmed with our symptoms, and having some words to describe it. And then it's even better when with physical therapy and other medical treatment, we find relief and we can find adjectives that describe that. So some of my patients who get relief, they'll say it feels freeing, it feels airy, it feels open. And so I like having those words there because it gives access to reproducing the relief as well. So urgency is a great word too. And then finding words that help you feel better too. And I know that sounds silly, but having a vocabulary for yourself is important. And then having words to describe to your practitioners is also important. Okay. So prevalence, I thought this was interesting because I could not find any consistency in terms of prevalence for patients. And I think we all know that, but I even found less information for people with penises or men because in the past, IC has been thought to be, of course, more female dominant, which is why everyone is here today. So the CDC said that 1 out of every 100,000 has IC in the general population, or 5.1 out of every 100,000 has IC. The study done by the VA in 2022, or published in 2022, said that the national prevalence was 0.87%, whereas women comprised of 1.08% in that database that they used, and male patients had 0.66%. So consistently in older studies, I found that it looked like, 2 out of every, I would say half of the population or half of the people experienced IC are women, half were men, but in the studies, more women said they had these experiences. But we'll move on and talk about why we think that male patients are underdiagnosed with interstitial cystitis. We think that part of that reason is because it's lumped in with chronic prostatitis and chronic pelvic pain. So typically, when I treat a male patient, they will say, "Oh, I've been treated for prostatitis for 10 years and nobody ever told me this could have been interstitial cystitis." Whereas in reality, for a while, they have had symptoms of interstitial cystitis, but they weren't never diagnosed. Chronic pelvic pain is another diagnosis that gets lumped in there as well. And so that's part of the reason why I think potentially male patients get underdiagnosed. That's lumped in with that diagnosis. And this study, the graph on the side, it shows the prevalence of each chronic pelvic pain or chronic prostatitis as compared to interstitial cystitis or bladder pain syndrome. The study, take it with a grain of salt. There's not a lot of participants in this study. And as you can see at the bottom, the 16, the 8, and the 22 are talking about amount of participants. So if we're thinking of research, that's a super small sample size. But that's what I was dealing with. And I think that's what we all deal with when we think about looking up men with IC. There's not a lot of information out there. Okay. And so leading to underdiagnosis and then delay in care for male patients with IC. And so I found this as you can see, I love research articles, so I'm going to include some of those and some anecdotal evidence as well from my practice. But a study done in 2022 or published in 2022 interviewed people in terms of their diagnosis and their symptoms that they experienced. Unfortunately, again, it was only 10 men in this study and only 27 women. So again, take it with a grain of salt, but I thought this was interesting. Women reported higher pain intensity, whereas pain interference with function was equal for men and women. So while the numbers were higher for women, men still said that the pain and symptoms interfered with their daily function just as much. They also reported equal amounts of depression due to their symptoms. But this is the tidbit that I thought it kind of really stood out to me, was it took women longer to get diagnosed, which was weird to me because the diagnosis is more prevalent, or we thought more prevalent in women. And men felt heard and affirmed in the doctor's office, whereas women felt ignored. I thought that was a little anecdote I was surprised about. In terms of impact on life, men reported their symptoms to be urinary frequency, disturbing their sleep. And so urgency and frequency really was the top thing that they said impacted their function, whereas women said the pain, so bladder pain was their biggest thing. So a lot of the time when I start treating a male patient, the first thing they say to me is, I just pee too much. I pee every 20 minutes. Whereas when I see a female patient, their complaints or reports are typically like, it hurts. My bladder hurts. My pubic bone hurts. But, everyone's a person, and this is just an anecdote, right? So everyone's very unique, and you could have all of those symptoms or none. And so in terms of that research article, I thought that was interesting. Okay. And so we could stop here for a moment and kind of say, what symptoms do you think are the most disruptive to your daily function? I saw like pain, urgency, but if you feel comfortable in the chat or unmuting yourself, what is the most disruptive part of IC? You're muted.
For me, it was the urinary frequency, which completely interfered with my daily schedule.
Mm-hmm.
Not so much, I would sleep during the night, but during the day, it just completely disrupted my schedule.
Mm-hmm. Yeah. And if you can't say it out loud, you can also frequency, urgency, suddenly having to go, that need to I gotta find a bathroom right now. It's hard to be a professional when you're having these symptoms. So I didn't set this caveat, but if anybody needs to go to the bathroom in the middle of the presentation, go ahead. That's okay. It will be recorded. Bio breaks are completely fine. That's okay. And I'd say that to my patients as well. We're human, and part of the training will be working on that frequency. But it's not helpful to push past pain. And so if you have to go to the bathroom. Oh yeah, airplane travel, that's true, any travel. I always get an end seat in a plane because I'm like, I gotta have access to the bathroom. I gotta be able to get up. I don't wanna make the people next to me move. And we start to plan our lives around these symptoms, which is super disruptive. And so thank you for sharing. And so I wanted to ask, what is normal urinary frequency? I don't like the word normal, hence the quotes, but I wanted to see what y'all thought normal was for one day. think you're muted again. Oh, still muted. Okay. Every 3 hours. Oh no.
So can you hear me?
Yeah, sorry, Mark. I cannot hear you. Is this Roger?
This is Roger.
Okay.
Yes.
Yes, sorry, I can hear you. I'm sorry, Mark.
Oh, so the
Oh.
worst problem for me, and I've had this for some years now and have been treated in a variety of ways, but losing sleep is extremely difficult for me. I mean, I have to get up anywhere from 10 to 12 times and sometimes more than that each night.
Wow.
And then try to go back to sleep. And I take gabapentin to help me go back to sleep faster, but it's still a problem.
Mm-hmm. Yeah, that's a lot. That's very disruptive.
Yes, it is.
That's more hours than you're in bed.
Yep.
Maybe. Yeah. Okay. So for the frequency, every 3 hours, I see 6 to 8. Go 6 to 8 hours. Yeah, not us. No, you're right. I don't know if Mark, you're able to put it in the chat. If you are, you can put your number or unmute.
Yeah.
There you go.
Uh,
So for what I say is typical, what I say is normal for patients is 6 to 8 times a day. And so that goal seems unattainable for some of us. That goal is scary. 6 to 8 times a day is a lot less than a lot of us go. Or we can translate that to every 2 to 4 hours. And at night, we think normal is 1 time a night or less. So if it's more than that, we call it nocturia, nighttime urination. And that's when it becomes disruptive to our daily function. But 6 to 8 times a day is the goal. Every 2 to 4 hours is the goal. But for some of us, if we're going and we're starting with, I go to the bathroom 20 times a day, I'm not going to make your goal in physical therapy 6 to 8 times. We're going to start with getting from 20 to 18 to 16 and trying to decrease it very slowly. But yes, the typical is 6 to 8 times a day. And that's with caveat of coffee and water intake. Okay. So I really wanted to go over the pelvic floor muscles and kind of the anatomy of what's going on. I did see previous expert speakers were PTs, I believe. So I wanted to go over the male anatomy for this area and really focus on what's going on here. So let's get our bearings first and try to figure out where we are. Okay. So right up here, we have the front of the body, and this is a hemisection of a human. So if the person is facing sideways and then cut in half, that's what this view is looking at. The front is the abdominals. Can you all see my mouse moving? Okay, great, thanks. The abdominals, the back, we have I'm just gonna move the chat over. We have our lumbar spine, our sacrum, and then our coccyx, our tailbone is back here. We have our pelvic bone, that's kind of shown on this side. So this is the right pelvic bone, and then our pubic bone is up through here. That's the bony anatomy in general. And then we can think about the organs. So we have our bladder up in the front. So this is the bladder, the quote unquote evil organ that we're here for. We don't want to demonize it, but that's the bladder. Leads through the prostate into the penis and out the tip of the penis. So the path of urine out the bladder goes through the prostate. And some of my patients have prostate related issues, not related to IC, through the penis, out through the tip of the penis. And then for other organs, we have our colon, so our large intestine, and then our rectum, and then the anus. So I show you this so I can say, like, look how close everything is. It is so close to each other. So all of these organ systems are going to be impacted by interstitial cystitis. And then at the bottom, we have our pelvic floor. So that little region here, these are the anal sphincters, and this is the pelvic floor bowl. And we'll talk about those a little bit in depth too. Any questions about where we are, like where in the body we are?
No.
Okay, great. So we're going to move on to let me make sure the chat. Okay, how common is constipation in development? So that's a really good question about bowel movements. Bowel movements, there is kind of this fallacy out there that you need to go to the bathroom every single day. And for some people, that is the case. That might be your normal. In terms of like what a typical textbook normal is, it actually ranges to 3 times a week to 3 times a day. So everyone varies in this kind of realm of constipation or bowel movement frequency, but constipation is a super, super common thing for my male patients with IC. And we'll go over why that is. Do any of you guys experience constipation? Associate, if you feel, you don't have to answer the question, but you can internally nod if you're comfortable. Okay. Oh, the meds, yes, that is also the case. Okay, so let's go over layer 1 of the pelvic floor. So there are 3 layers of pelvic floor muscle, and this is the most superficial layer of muscle. So this is a person on their back facing you, so their legs are up this way, penis at the top. So penis, I'm using my hand, I should just use my mouse. Penis at the top, and then coccyx at the bottom. And so these muscles, this kind of orangey red, that is pelvic floor muscle. I have circled the muscles that are comprising the pelvic floor layer 1. So ischiocavernosus, bulbospongiosis, transverse perineal muscles, that has 2, transverse, superficial transverse, and the deep transverse muscle, and then the external anal sphincter. There's not going to be a test, don't worry. I just wanted to let y'all know the names of the muscles. But layer 1 primarily works with arousal and continence. So for male patients, that means sexual arousal. That can mean erection or erectile dysfunction, ejaculation, and then having pee and poo come out or pee and poo not come out, as well as gas. So we should be able to control our bowels and bladder, and then our sexual function. So a lot of people with IC have erectile dysfunction associated with it due to the proximity of those muscles. And so this ischiocavernosus muscle here and the bulbospongiosis, those help the most with erection, and then with ejaculation too. Okay. Let's go to layer 2. So this is an under-discussed layer, and I couldn't find a great picture for male patients because it is hidden in this kind of perineal membrane. But layer 2 is comprised of the external urethral sphincter, the deep transverse perineal muscle. So that's not here. This is the superficial one, but underneath of it, it's a muscle very similar called the deep transverse perineal muscle, and then the perineal membrane. So that's through here. This group of muscles are very important for continence. So not peeing and pooing, but peeing and pooing if we would like to. Okay, and then layer 3. So this is what people classically consider the pelvic floor, and they ignore those other layers. So this is the levator ani layer. And the muscles that I have circled are comprising the levator ani. So the puborectalis muscle, the iliococcygeus, and the pubococcygeus. The other muscles here, the ischio-coccygeus and the piriformis, and the obturator internus, are co-workers. They're not actually muscles of the pelvic floor, but they are co-workers and they work closely with the pelvic floor. This layer is a primary support layer, so it holds up our organs, and it connects to our abdominals and our hips and our low back. So it's a very structurally sound part of our body. Okay. So let's go on to functions. Any questions about the anatomy? Okay, great. There's a lot of detail out there if you want to look into like radiograph reports, looking at anatomy, but that's not your job. Even if you're interested, it is. But there is a lot of information out there, and we're going to talk about the pelvic floor as a whole. So we're going to go over the pelvic floor muscle functions and then the dysfunctions. So function, the first one is pelvic stability. So the ability to kind of walk, lift, and move around is because that deep layer 3 muscle group holds us up. It gives us pelvic support and it connects to our hips, back, and abdomen. When this dysfunctions, we might see weakness in the hips, the low back, and the abdominals, flexibility related issues, and gait dysfunction. So gait means walking or ambulation. So a lot of us, as we get older, we start to have these issues anyways. So we start to have weakness in our hips. We start to walk a little bit differently. We get more inflexible. But But with interstitial cystitis, it can exacerbate some of those symptoms because of the connection with the pelvic floor. This is one of my favorite analogies. So the pelvic floor, the hips, the abdominals, and the low back are coworkers. And when one coworker isn't doing its full job, the other one takes on a role, it gets burnt out. So the pelvic floor tends to be the working horse of that region of our body. It tends to take these roles away from the hips, the low back, and the abdomen and become very hypertonic. And so when the pelvic floor muscles are tight and overworking due to pain from interstitial cystitis, the hip muscles get weak, the back can get weak, and the abs can get weak. And it becomes this self-fulfilling prophecy of like weakness, overuse, and pain. So a lot of my patients do have some of these gait-related issues, and some of that will happen after like a hip replacement, or just it will form over time from having pelvic floor-related issues. Second function is support. So the pelvic floor is one of the only things holding up our GI system, our urinary system, and our prostate. And so when that doesn't go well and we have dysfunction of the pelvic floor, we can get a prolapse. And so people that are constipated, they might push and push and push and strain to have a bowel movement because the muscles of the pelvic floor are tight. Or you might do the same thing to have to pee. You might be pushing and pushing to pee because you have the urgency, but nothing's really coming out. That can lead to prolapses long-term. It is less common in people with penises to get a prolapse. For the male pelvic floor, for the male pelvis, it is a smaller, more narrow area than the female pelvis. And so it's less like, also there's no vagina. So there's less likely things falling out, but sometimes there will be a rectal prolapse. So the rectum will actually start to come out of the anus after years and years of having bowel and bladder related issues. And so I see that later on with some of my patients. And that, I don't want to blame interstitial cystitis, but it sure doesn't help if that's the issue. We have voiding issues, so issues with peeing and pooing, because if the area isn't being supported, things kind of fall down a little bit. It's harder to empty. Pain can be associated with that, and then breathing dysfunction. So that sounds out of left field, the breathing dysfunction thing, but the diaphragm is a very important part of our pelvic floor pressure system. So diaphragm is under our rib cage. Okay, pelvic floor is at the bottom. So it creates this pressurized system like this. And if our pelvic floor isn't moving, it's tight, it's not working to its full potential because of a painful bladder syndrome diagnosis, the diaphragm starts to dysfunction too. And so there's kind of this incongruity with these muscles. They should be working like this when we breathe, but they work against each other. And that's especially the case for people with asthma, COPD, smokers. And so all of those things can exacerbate pelvic floor related issues. Okay. And I will go over the diaphragm connection a little bit more in depth, but I thought I would leave it there. Sphincters. So sphincters are circular muscles that open and close, and the pelvic floor's third function is to control urine, gas, and stool. I've had a few patients that I've asked if they have incontinence, and my favorite answer is, or when I ask about gas, they're like, oh, we're supposed to be able to hold back farts. And I think that's one of my favorite things, because to live your entire life and not be able to hold back a fart sounds so freeing. Like, it just sounds freeing. But yes, we should be able to hold back urine, stool, and gas. And the analogy I give for people with like pelvic floor related issues and they can't figure out those muscles, I'll say, what if you're in an elevator with 5 different people and you're about to pass gas? What do? And then that'll get them to Kegel really fast if they know that they can control those muscles. And so when these areas dysfunction, we get incontinence, we get incomplete emptying of urine or stool, especially if it burns and hurts to pee. Of course, we're not going to empty fully. We're not going to want to complete that urinary stream if it's painful. Hesitancy, so we can't start the stream. It's not starting, like we're like, okay, I got to pee. You're standing in front of the toilet and it's like, okay, like let's get it started. But it's not starting, or a weak stream. So the pee is super weak. And I know for my male patients, I ask about acoustics. So depending on where your urinary stream hits in the toilet bowl, whether it's on the porcelain, whether it's on the water, it sounds different. And so I'll ask my patients if they're not sure about the urinary stream strength, is does it sound weaker? Depending on where you hit the toilet, does it sound less forceful? And that typically will help people say, oh, okay, it sounds, it's quieter now than it was before. There also could be pain with peeing. We talked about constipation, and then recurrent UTIs. The issue with recurrent UTIs is that IC, interstitial cystitis, sometimes feels like a UTI. So a lot of people will have recurrent diagnosis of UTI and prostatitis before they even get diagnosed with IC. So they have this kind of like problem of going to the doctor, going to urgent care, going to the ER, getting antibiotics. Their symptoms kind of get a little bit better because it helps with inflammation. And IC can be associated with inflammation, but then their symptoms come right back, and they do that cycle over and over and over again. So with UTIs, I like to tell patients, if it feels like your IC symptoms, it's probably not a UTI, but if it feels extra worse, I would get tested for a UTI. And the reason that UTIs can occur because of these pelvic floor muscles is if the stream isn't strong enough, bacteria isn't getting cleaned out of your urethra. The penis is a long portion of the urethra, and it has no sphincters in it. And so it needs to have enough force coming out to push out the bacteria. And if that doesn't happen, you can form a UTI. Okay, and then sexual function. So sometimes my patients will come as like a secondary thing. They'll say, well, I have IC, I'm having urinary frequency. Oh, but also I've had erectile dysfunction for 30 years. And I'm like, oh, okay, so that's probably been an issue for a while. And for a lot of my male patients, they're more hesitant to discuss that, which I understand. But it is definitely relevant to the situation because of that connection to the pelvic floor. So the ability to enjoy consensual or independent sexual experiences should be attainable for everyone. And if it's not, and you've done like your due diligence medically, Viagra, Cialis, whatever you use, it might be a pelvic floor related issue that might have stemmed from your interstitial cystitis. So the ability to sustain an erection, if that's something you would like to do, is in part due to the pelvic floor muscles. And so talking about that, if you're comfortable, can be a part of our plan of care. Sometimes it comes as like a secondary thing, but some people come to me with the primary goal of I have dry orgasm or I have a weak ejaculation, and pelvic floor physical therapy can help those things if it is due to the pelvic floor muscles. And so when this part of our pelvic floor dysfunctions, we get sexual dysfunction, ED, pain with ejaculation. If we look at I'm going to go back to these incredibly slow transitioning slides to show you some of the anatomy again. So ejaculation occurs through the urethra. So it's coming out of this area, and interstitial cystitis does impact this region. So regardless of if it's pee or if it's ejaculate, it's going to be painful going through a flared up area. So sometimes, I think my favorite analogy, not favorite, that's the wrong word, was it feels like I am ejaculating knives. And that sounds horrible. That's horrible. And so having an idea of how we can work with the muscles to relax that area and have it less painful can help with ED. Going back to the sexual dysfunction, and then difficulty with orgasm, and then pain after sex. So we should never have pain with sex. There should never, ever be pain with sexual intercourse. And if there is pain after sex, that's probably an issue that you should talk to your medical provider about. And if it is your pelvic floor, we can work on that in pelvic floor physical therapy. Okay. And then safety. So this is one of my biggest things that I hit on during my evaluation with patients is the safety response function of our pelvic floor. So the pelvis, the pelvic floor, is a protective response system. Have you all ever heard that phrase, I clenched so hard, I was so anxious, I clenched my butt so hard? That anxiety response in our body. That is the pelvic floor responding to either pain, trauma, or stress. So stress, pain, and trauma trigger the pelvic floor to act. It triggers it to contract and tighten. And so that's a thin line because that's an evolutionary thing. Having this evolutionary response of protection is important. It has kept us alive for thousands and thousands of years. But it's not helpful when there's no damage actually happening. Interstitial cystitis or painful bladder syndrome hurts like heck. So of course our muscles are going to respond by tightening up and protecting us. And so when that happens, we have hypervigilance, so too much response to stress. The pain can become too much. We have these trauma responses, and we have voiding dysfunction, sexual dysfunction. All of the functions of the pelvic floor can dysfunction due to this response system. So there's a fine line between function and dysfunction. And a lot of the times, I just put this question up here is because by the time you get to physical therapy, you're at the dysfunction phase, right? You're not going to go to PT, or it's not common that I see patients that are like, I was just diagnosed with IC. I don't have that many issues. Can I prevent things? It's more of a, I've been dealing with this for a really long time. I'm at dysfunction. How do I move on? Okay. So we're going to start talking about the high tone pelvic floor. So as a result of that overactive, that hypervigilance, our pelvic floor becomes hypertonic. So I really want to impart that there's a difference between tonicity, tone, and strength. I know in like the workout world, you're like, oh, I'm super toned. That's great. But for the pelvic floor world, for all muscles, actually, tonicity, having tone, is passive. We're not thinking about having tone. It's just kind of there. Strength, however, is volitional. It's on purpose. And so tonicity is what my patients with IC tend to have. So there's this kind of tension in the area that's just always there. I like to relate it to bruxism, or teeth grinding. That's another way that people have tonicity, is they constantly will grind their teeth together. You're not trying to do that. It's not like you're not saying I'm going to grind my teeth together right now. It's a response. It's kind of this stress response thing, especially at night. So we kind of wear those mouth guards to protect ourselves. Another area people hold tension or tonicity in is their neck muscles. So when they're really stressed out, they'll start to like raise their shoulders up, so their earrings. And so that's another tonicity type response. And that's not strength. So people might come and have tight pelvic floor muscles and say, oh, tight's great, I'm strong. But tonicity does not equal strength. So it takes a lot of time for people to understand that they have weakness, but also too much tone. And so that can be tough to deal with. And so that creates pain, pelvic, abdominal, low back pain, hip pain. It can even create neck pain. If we're moving our body differently because of bladder pain or because of frequency, and we're chronically holding those muscles like this, our whole body changes. The pelvic floor is like the cornerstone of our body. How we hold those muscles really does impact our full body, our breathing patterns too, which leads to voiding dysfunction, sexual dysfunction. That's kind of a trend you all have seen, as these issues are recurrent and they're repetitive, and they play on each other. All right, before I jump into the physical therapy component, any questions?
No.
Awesome. And if there are, please put them in the chat and I'm happy to answer them. So what comes next? And we're going to go over physical therapy. So that's why everyone's here. Has anybody here done pelvic floor physical therapy?
Yes.
Was it helpful?
Yes.
Okay, awesome. Are you saying that to make me smile? So I'm hoping that there is, if anything, the goal of PT, I like to teach people things, give them more autonomy of their symptoms. And so I'm going to go over a physical therapy evaluation, still in it, nice job, keep it up, what that is comprised of, and what it kind of looks like. And that's, it's different for every pelvic PT. Who you see is different than who I am. And so it's okay. We all have our own methods. But we start with a subjective and then go to an objective. So we talk. My first session with patients is typically an hour. And as you can see, this is a lecture, but I'm a talker. And so my patients and I have a good discussion and we get to know each other. And then the objective measure. So what is happening in your body? We take measurements with that little thing right here is called a goniometer. And there's a lot of other tools that we can use in PT to objectively measure what's happening in your body. So subjectively, I like to get your history, your current symptoms, functional levels, pain. We do talk about diet. Not every PT does, but I talk about diet. I'm not a dietitian, but I have a general idea of the interstitial cystitis diet, and I know my limits and when to refer out. We talk about fluid intake, and then I just kind of leave it up to my patients to ask questions, set up what they want to go through. I will always ask my patients, what is your goal? I always have goals, of course, but it really doesn't matter what my goals are. Your goals are what matter. And so subjectively, we get to what that is. And that might evolve as you start going through therapy and have multiple sessions. You might come in and say, oh, hey, Sam, I thought of this other thing that's not like that I want to talk about, and that I'm more than happy to discuss with you. So subjectively, we chat, we figure out what's going on. We look through medical history because that's very important, medications and stuff like that, and then go into the objective measures. And so this is a very variable part of the evaluation. So it really depends. We usually, what I like to do is start with the hips, back, abdomen, and breathing patterns. So the adjacent, those coworkers I talked about earlier in the presentation, and then go from there. So seeing how strong your hips are is very, very important. Seeing your back mobility, your lumbar mobility, your abdomen, is there tension in that area? And then your breathing pattern. So are you doing a nice deep belly breath? Are you using your diaphragm to its full potential? We also go over toileting mechanics. And I love when I ask patients to show me how they go to the bathroom on the toilet or on my little treatment area, pants on. And they're like, you want me to show you what? And so I'll kind of just, as an open forum, say, show me how you go to the bathroom. And so it really depends. They're like, is it pee or poo? And I ask for both. I want to see how you're peeing and pooing. And then sometimes I will suggest a squatty potty. I'm hoping that we've heard of those things, but it does help with relaxing the pelvic floor muscles. And I might even suggest that you pee sitting down, which for male patients is sometimes like not going to happen. And that's okay. It's just a suggestion. But if we think about those those connections, sitting down takes the hips and the back and the abdomen out of the situation. And it's just that pelvic floor. We can relax all the other muscles and then use the pelvic floor adequately. So it's up to you. So I typically will say, can you try to sit to pee if you feel safe? So, having the ability to stand to pee is enviable. So if you're in a place that doesn't have a clean toilet, like, do your thing. But if you're at home and you have a safe place, it's easier to pee sitting down. It also tips the pelvis forward. I'm not going to scroll all the way back to that let's get our bearings picture, but the penis has this dip that goes this way, and urine will get stuck due to gravity if we're standing here. So the penis is here. It'll get stuck before at the base of the penis. And if we sit down, it tips it downward and can empty that urine more fully. So that's something I go over with patients. And then the last but not least, and it doesn't have to happen during the initial evaluation, is the pelvic floor muscle exam. And so that is super dependable. Sometimes sitting helps, sometimes standing straight up. Oh, I love the arms overhead, Bob. That's a really good idea. So that's with that intra-abdominal pressure system. I love that. How we look at our pelvic floor muscles depends on each human. So sometimes we can do an external visualization. So that is pants off, but top on. And I look at your muscles externally. And so I ask, can you do a Kegel? And some people say, only women Kegel. I'm like, no, we all have pelvises, all pelvic floor muscles. We all can Kegel. So I see, can you do that contraction? What happens when you bear down? What happens when you push? What happens when you cough? And then from there, we can leave it at that. We don't even have to do that for the first time. We can just start with the adjacent body parts. But if we're going to talk in depth today, urinating warm bath or shower sometimes helps. That's really smart because the warmth, I'm looking at the chat right now. The warmth is a muscle relaxer, and I'm assuming that helps relax your pelvic floor muscles. And so that warmth will kind of seep into the muscles and let that high tone dissipate. And so I like to teach my patients alternate ways when they can't access a warm bath or shower, how to relax those muscles, but that's smart. All right. And then we can also do a muscle exam. So that muscle exam is variable and it depends on the patient. It can be an external exam. So I'm touching the muscles on the outside with a gloved finger, or we do an internal exam. And this is where a lot of my male patients are like, nope, not happening. And that's fine. And that is done rectally. Since you don't have a vaginal canal, the only hole that we can access is the rectum, the anus, and the pelvic floor muscle exam is rectal. And so that really depends on your comfort level. If you come and meet me and you're like, no, that's never going to happen, that's fine. There are other options, but it is the most in-depth look at those muscles. And I'm gonna do the transition back to one of those slides, but I'll show you the muscles that I look at when in when I do a rectal exam. Okay, hopefully, yeah. So this is the layer that I am palpating, I'm touching when I do a rectal exam with a glove digit. These specific muscles, the puborectalis, pubococcygeus, and iliococcygeus, all have different muscle fiber orientation. So those little lines that you can see here, the lines go this way and they go this way. So it's super cool because with practice, I can actually tell the difference between each individual muscle, whether it's right side or left side, iliococcygeus, pubococcygeus, and then let you know which specific muscle is dysfunctioning. And we can do certain treatment techniques based on that examination. Okay, now let's take our long trek back to where we were. There we go. Okay. There's also biofeedback, and I don't know if anybody has heard of that, and I'm hoping you have if you've done physical therapy. It's a less invasive, or can be a less invasive technique to look at your muscles, and it is done via electrodes. So if you've ever had a heart monitor, it's similar to that, but it's put outside of your anus or into the anus if there's a rectal electrode, and we get to see visually what happens with your muscles. I will go over that in a little bit. And it really just depends on what you're comfortable with, and you're in complete control. There is never a time where I will do something that you have not consented to multiple times. And if you're in the middle of the examination and you're like, I'm having a trauma response, I'm uncomfortable, we stop. So that is how pelvic PT should be, and you should always be in complete control. We are just here to make recommendations, and you are there to say what you're comfortable with. Okay. I wanted to emphasize, though, that we're not thinking of this in isolation, in a silo. We're thinking of it in the whole realm of what's going on. So here, I'm not speaking to the medical management of IC because that's not my scope of practice, but you should be being managed medically via a urologist, a primary care provider. Somebody should be managing you. There's injections, there's bladder installations that are possible for treatment. Sometimes topicals can be helpful to relax the muscles. Dietitian can be a super helpful resource if we're thinking about the IC diet, and then mental health support. And so let's talk a little bit about physical therapy. Hope we're doing good on time. I'm gonna speed up. So we are going to be talking about what we're treating here. So we're not treating the diagnosis of IC. I wish I could, but I can't. I'm sorry. We treat the limitations and dysfunctions that you have as a result of interstitial cystitis. And that might be muscular, so coordination, control, awareness, weakness, and flexibility related. And that might lead to pelvic floor muscle training. And I did see, I think you had a previous provider talk about Kegels being an absolute no for people with interstitial cystitis. And I have mixed feelings about that. So Kegels are those muscle contractions, the muscles of the pelvic floor tightening on purpose, like the strength the volitional contraction. I don't think Kegels are out of the question because I think it helps people find where their pelvic floor muscles are. However, since people with IC tend to have that tension already, I'm not going to have you do repeated Kegels throughout the day. It's going to add to the pain and dysfunction. Planks, that's a good question. I typically don't advise against any exercise, but what I do try is in my sessions, and I'm answering Bob's question, can you relax your pelvic floor muscles while you're doing those exercises? And so having an awareness of what that is, so, your plank, you're using your core muscles, whether it's hands or forearm plank, you're tightening your abdominals and your pelvic floor is part of that system, but can you check in with those muscles and let them go? And then after the exercise, can you let them go? Because a lot of us who do those muscle exercises, we keep them tense. And so checking in after. Long sitting on an airplane. I'm going to have to think about that, Rich. I think it depends on what relaxes you, but I typically will recommend my patients do certain yoga poses, such as happy baby, child's pose, a deep squat, and deep belly exercises, deep breathing exercises to initiate urination after prolonged sitting. We also talk about nerves. So the nervous system is super important for the muscles. So it runs through the muscles. And if we're not moving a lot, those nerves get tight. Fascia, so connective tissue, and scar tissue. Having a history of abdominal surgeries can impact our function. And so treatment options for the adjacent body parts, we're thinking about the hips, we're thinking about the spine, the back muscles, the abdominal muscles, and the diaphragm. So if you're in pelvic PT and they're not addressing those areas and they're just zoning into your pelvic floor, they're not looking at the whole scope. And so there might be a reason why they're doing that, and that's okay. But there should be at least an assessment of all of these areas to make sure that they're not playing into your high tone pelvic floor. I said I would talk about the diaphragm. Here's a picture that I love. When we inhale, our diaphragm descends. It opens up like an umbrella in our rib cage. And as a result, our pelvic floor should go down and relax. So a big tip of like a foundational move that I teach my patients is deep belly breathing and deep diaphragmatic breathing as a way to initiate urinary stream. If you can't get the pee started, you can't end the pee stream. Deep belly breaths can be super helpful, and having awareness of how to relax those muscles. And a lot of the time when I do assess the breathing patterns, I'll see this chest pattern. So I'll say, okay, take a deep breath. And my patients will go, and all that does is that pulls up on the pelvic floor muscles and adds more tension, makes it harder to empty your pee and poo. Okay. And then the behavioral changes. So this is the stuff that gets pretty tricky because it's the hardest thing to do is to make changes in our life. We have habits and it's hard to break them. So the IC diet, I'm hoping we all kind of know what that is, but we're avoiding spicy foods, citrus, tomato sauce, caffeine, alcohol, all the really fun things in life. But it's something that will irritate the interstitial cystitis. I like to tell my patients that I have celiac disease, so I am allergic to gluten, and I have successfully found food that I love that doesn't irritate my gut. So there are ways to find foods and drinks that are good and don't irritate the interstitial cystitis. But there's a caveat is if you do drink or eat those things that irritate your bladder, it's going to cause a flare or may cause a flare of your symptoms. Exercise is super important, not just physical therapy like pelvic exercises, but general exercise. So having some sort of routine that you like to do that gets you moving. Stress control. And so I really like to talk to my patients about this. And I do tend to see more hesitation from male patients when I recommend that they see a talk therapist, because some things are stress related. And that is because pain from IC and having this dysfunction, this urgency, this disruption in sleep causes higher levels of stress. And then it becomes this prophecy that just continues to be self-fulfilled. And so if you can speak to a talk therapist, see a psychiatrist if medication is appropriate, it's helpful, even to get you out of that pattern and get you started on a relief pattern and to get out of the flare. That can be helpful too. Time avoiding, so working on elongating the time between your pees, and then your toileting habits. So that's sitting to pee if you can. How are you ending your urinary stream? Are you doing a Kegel at the end? Are you bearing down? Talking about that, and then deferring the urge. So I don't know if everyone or anybody has heard of PTNS. So it's a tibial nerve stimulation. It goes into the lower leg, and that activates the nervous system. But there are also ways to do so via our pelvic floor and our heels, our gastrocnemius and soleus muscles. So I like to teach patients how they can defer their own urge to pee and hopefully make it to the bathroom in time, not have any leakage. That's super helpful. The marathon runners, Bob, I commend you for running marathons. If you see me running in Philadelphia, you should also run because something's wrong. I don't run, but in order to, okay, let me read it. So I wonder if part of that need to pee, well, interstitial cystitis, Bob, but if there's adjacent hip weaknesses and parts of your body that aren't working to their full capacity, a lot of my runners have strong hip flexors and strong glutes, but when I get into the hip rotators, the muscles that turn around, those are the ones that support our pelvic floor. So really working on external hip rotation, so the muscles that open up our hip, those closely connect with the pelvic floor. So I would look into that and then work on endurance-based hip exercises to see if that helps. And then really talking about like, what are you drinking before? Are you having like a pre-gel? And is that pre-gel or whatever sugar supplement you're having with the marathon. If it's irritating your bladder, is there another option? Because, you know, for a marathon, typically people have something that they take so they're not going hypoglycemic. And I do remember one of my friends takes these pre-gels and they have a lot of sugar in them to give you more energy, but they are acidic and they will irritate the bladder. Okay. Biofeedback, we'll quickly go over this. I apologize, I'm going over. Biofeedback is a assessment technique and a treatment technique that we can use for the pelvic floor muscles. So we attach electrodes to the pelvic floor and it gives you a visual representation and an auditory representation as to what's happening with your pelvic floor muscles. Some people don't have any awareness of what your muscles are doing, and that makes sense. It's an area that's in a cave. We can't see it. We're not looking at it all the time. So if we can find a visual representation, it can be helpful. I will also sometimes use electrical stimulation. So I don't know how many other PTs do it. I couldn't find any current studies on the treatment of IC and E-stim, but I hope a lot of us have heard of TENS. It's like this, it's a muscle stimulation thing that helps with pain. I will actually sometimes do that for my patient's pelvic floor, and it helps them relax. It helps calm down the nerves and get them out of a flare so we can then do exercise and move forward. I've been using it a little bit more recently and it's been helpful. And so there are machines that you can do it at home. I typically start in the clinic and then we go from there. This unit here is Prometheus. It's the brand. That's the one that I use in my clinic. Okay, we're almost at the end. General exercise as a PT, it's my bread and butter. Movement rules, motion is lotion, get moving. Moderate levels of aerobic activity can modulate pain. So it helps. It's a great stress relief, and then it can strengthen weaker muscles. So I love to play tennis and kick my partner's butt at tennis, and that both releases endorphins and makes me happy. So finding something that gets you moving, but then also brings you joy is important too. Some people, when I tell them to do PT exercises, they have this like, oh, I have to do that every day. And we'll find ways that we can work together for your specific exercises, but then sprinkling in things that you're passionate about. And that might be biking, that might be running a marathon, that might be yoga, and we can figure out ways to incorporate that into your treatment. Stress management is super important. I'm going to move on and say, if I think that there would be benefits from seeing a psychologist, I will recommend a psychologist, but you have to decide if you're comfortable with seeing one or not. Okay. And then pain. So this is, I think, one of the last parts of the presentation that I want to spend a little bit of time talking about. Pain, I didn't even define it here. And I think I liked not defining it because I couldn't find a good definition of pain that I felt good saying. But pain is telling us something is wrong. It's a signal from our brain saying something's wrong, something's not working right. And it compounds on itself. So the more pain that we have, the more pain that we experience. It's so personal and it's so subjective. That's why I like to ask patients for adjectives. How do you describe your pain? And so that gives them something to hang on to rather than just pain. Because I do understand that it's frustrating when every provider you see is rate your pain from 0 to 10, 10 being going to the hospital. That can be so repetitive. And it pisses me off too when I see certain doctors and they're like, tell me your pain level. I was like, I just did. But anyways, we do ask as a barometer, but then understanding that pain is complex. And depending on how you feel that day, you might feel it more and it can compound. So you prove pain to yourself by when you do something and it's painful and it happens again. That's a neural pattern that comes into our brain and says, oh, it's going to be painful again. It's going to be painful again. So it's this kind of, again, self-fulfilling prophecy. This is an analogy that I like to use with my patients. In this day and age, I don't hope, but we all get spam calls, spam emails, spam texts. Do you answer all of your spam calls? I'm hoping you don't. I did have one patient that I asked and they said yes. And I was like, okay, well, that's a moot point. But I like to relate pain to spam calls. We get the notification, so we feel that pain, right? But we get to decide if we're going to answer that, if we're going to answer the call to pain and kind of figure out what our response is going to be. Do we want to mute the cell phone? Do we want to block the caller? And that's easier said than done. But for pain, we can find ways that we can mute that caller and find ways to kind of diminish the pain. I do recommend Adrienne Lowe's Why Do I Hurt? It's a patient-friendly book about pain neuroscience. Oh, okay, promise, this is the last slide. So a little bit more about research. 71% of men in a study done in 2015 said they had sexual dysfunction. Prostatitis, like I said, is typically the first diagnosis. And there are no studies currently on interstitial cystitis in male patients and the efficacy of physical therapy. But it does say for male patients, physical therapy can help with chronic prostatitis or pelvic pain. Lastly, there's this interesting U-point phenotype that goes through a 6-point scale. And with the dot with each of those, so the urinary symptoms, the tenderness of muscles, those things listed, based on your answers, the provider who's managing your IC can find a great way to provide a treatment plan. So if tenderness of muscles is your primary complaint, they might send you right to physical therapy. Whereas if there's like an infection, they'll treat the infection and then go from there. All right, finally, the questions. All right, so Bob, let me answer that one. Oh, that's a really good question. That's hard because interstitial cyst. Oh, so let me read Bob's question. How do you set goals or know when you are done with pelvic PT and that it has taken you as far as it can help, or as far as it can help? That is an amazing question. And it's a conversation I like to have with my patients on their first visit. So setting expectations to physical therapy is huge. If you come into my treatment room and say, I want 100% resolution of my symptoms and I never want to feel pain again, we're going to have a conversation about figuring out what your goals are and how we can make them actually attainable, because pain is a part of life, and having tools to manage it is my goal for my patients. I think for how can you tell if PT has run its course is, can you independently manage yourself for a little bit? I typically will do a month trial of independence and see if I have any improvements with my patients. If not, we might discharge and come back later if there's a flare of your symptoms. I hope that with the physical therapist, Bob, you set good goals and both of you talked about what's attainable, what's not attainable. And if those goals have been met, that's a really good way to tell. If those goals weren't attainable, that's another question to talk about with the PT and decide, should we change the goals and what should those be? I hope that answered. Any other questions? John, I think there will be a recording available. Yeah.
Yes, there will be a recording that we send out. Okay, I think we got all the questions. Thank you so much for being here with us tonight, Sam. The session was so very informative. We hope all of you enjoyed this webinar and learned something new. If you found this event to be of value, please consider joining us for future webinars and share these opportunities with your community. A friendly reminder to please complete the post-webinar survey that we have posted in the chat. We are also excited to announce our next webinar with Dr. Christopher Smith. He'll be presenting on his 20-year plus experience with Botox for treatment of chronic pelvic pain syndromes. So you can watch your email for more information on that. So thanks again, Sam. You are amazing. And I hope everyone has a great night.
Thank you for having me and thank you for participating. If you have any questions, I didn't include my email here, but if you would like to reach out to me, I don't know if there's a way to get to you all and then you can, I don't know, I can send my email.
Sure.
Yeah.
Yeah, we can maybe put it in the chat.
Yeah. Let me do that.
Thank you so much.
Yeah. I wasn't sure how many people would come and I didn't want my email out there for, I didn't want to be famous. This is an attainable amount. All right, awesome. I'm going to send that in. So that's my work email. And if you have any further questions, please feel free to reach out. If you want to know kind of any more information, I'm happy to chat.
Thank you so much.
Mm.
Thanks, everyone. Have a great night. Bye-bye.